Good evening, everyone. Thank you so much for coming for the lecture. Today, Dr. Aditya is with us to discuss on the diagnosis and management of myasthenia gravis. Over to you, sir.
Thank you, Jennifer, and I would like to thank the Department of Medicine and Neurology for giving me another opportunity to talk. And sir for organizing this medicine neurology sessions. Um, my topic for today is myasthenia gravis. Again, as in my previous talk, my primary focus of discussion will be the clinical and some amount of pathophysiology to explain, to understand the laboratory testing and a brief overview on what are the management possibilities in this disease. But my primary focus will be on the clinical presentation. So myasthenia gravis is a disorder which affects the neuromuscular junction. So, neuromuscular junction has a lot of peculiarities. It is a synapse where an electrical impulse which is coming from the nerve, which reaches the presynaptic junction, gets converted into a chemical signal in the form of acetylcholine, and then again becomes an electrical signal in the muscle. So, electrical. It's another area where the motor nerve fibers reach. I mean, it's an area where there is no motor nerve fibers at the junction. And also, it's another area where there is no blood nerve barrier, and hence it's rather naked, and so more prone for autoimmune disorders. So not just autoimmune, but even genetic disorders and even toxins can also affect the neuromuscular junction. So as I was just mentioning, from the ventral anterior horn cell to the motor root, the motor nerve, and then it finally, as the myelin stops here, and the unmyelinated nerve fibers finally, just as it touches the muscle fiber, there is this region. So there's a presynaptic region, there's a synapse, and there's a postsynaptic region. Very briefly, the biochemical things that occur at the presynaptic, synaptic, and postsynaptic junction is the formation of the acetylcholine, the release of the acetylcholine into the synaptic cleft, and how the acetylcholine acts on the postsynaptic receptor, and the acetylcholine being finally degraded back by the acetylcholinesterase enzyme. So it is stored in 3 different pools. So if we consider this as the end of the presynaptic junction, this is the synaptic cleft and this is the postsynaptic junction. Immediately just adjacent to the area is what we call as the immediately available pool of the acetylcholine, which is formed from the choline and acetyl-CoA. And as every nerve impulse comes from the immediately available pool of around 10,000 quantums of vesicles of acetylcholine gets released. And as it is released from the secondary pool, it gets replenished. So this contains up to 2 to 3 nerve impulses will be available from the immediately available pool. By the 4th and the 5th impulse, you need mobilization from the rest of the pool and from the main storage. So the acetylcholine so when the nerve impulse happens and there's a depolarization, calcium will enter into the cell, into the presynaptic junction, cause this complex set of enzymes and production of acetylcholine and the release of acetylcholine into the synaptic junction, where as the acetylcholine comes and binds to the acetylcholine receptor at the postsynaptic junction, each small molecules of acetylcholine will produce a small potential change, so which is called as miniature end plate potential. All of these quantums of 10,000 vesicles of acetylcholine, if they produce, the sum of these miniature end plate potentials become end plate potential of that muscle fiber, which produces a muscle action potential in the muscle fiber. Multiple such muscle action potentials will become a compound muscle action potential. So that's how a muscle contracts. So as each acetyl is just a diagrammatic representation. So each acetylcholine comes to the postsynaptic receptor, binds to the acetylcholine receptor, produces small depolarization changes on the membrane, that is called as miniature MEPP, and multiple such MEPP get summated to form end plate potential. So it has to rise above a certain level, then only the muscle fiber will twitch, what is classically called as the all or none phenomenon. So as it reaches that threshold, only will the end plate potential cause a muscle fiber action potential in the postsynaptic junction, that is the muscle fiber. and then multiple such regions are getting contracting, and that produces a muscle movement or a compound muscle action potential. So this summation is what is being one vesicle forming a miniature end plate potential, multiple such vesicles becoming an end plate potential, and as they summate, that produces a muscle fiber action potential and a compound motor unit action potential. So this is how the receptors are placed in the synapse. So you have the calcium coming in from the presynaptic region that will trigger the release of the acetylcholine. The acetylcholine will go and act on the acetylcholine receptor. It's a pentameric structure. The formation of the acetylcholine is also dependent on the aggrin, which is released from the presynaptic region. That leads to clustering of the LRP4 and MuSK, muscle specific kinase enzyme. And all of these clustering will lead to acetylcholine clustering. This is how which the acetylcholine will act. Sodium potassium depolarization happens, and there is some muscle contraction that is happening. So in pathogenesis, what happens is that this binding of the acetylcholine to the acetylcholine receptor is prevented either by the antibodies which block the action of the acetylcholine from acting on the receptor, or the antibodies will actually stimulate complement that will produce membrane attack complex that will damage the acetylcholine receptor and therefore again lead to nothing for the acetylcholine to attach. Or thirdly, by complement, it will also cause all of these acetylcholine receptors to coalesce together and they get internalized. So there are lesser number of receptors expressed on the postsynaptic junction and therefore also reduced amount. So there is a structural and functional reduction in the amount of acetylcholine receptors and even in the structure in patients with myasthenia gravis. So this is where I like, so this brief overview of the pathogenesis is important to understand the clinical presentation. So as in every syndrome, we need to understand what are the key questions that one must ask, what are the key presentations, when will you consider that a patient has a neuromuscular junction disorder. So the classical and the most important words which I want you to keep in mind after this lecture is that variability and fatigability. Variability means the deficits do not remain the same over days, that from days or from minute to minute or time to time, there can be changes. So that is not common in other neurological localization disorders. Maybe only encephalopathy can actually change like this, but otherwise neuromuscular disorders only this amount of variability, where in the morning they're a little better, by the evening they tend to be worse, or changes in the deficits, changes in the findings that you are documenting in subsequent OPD visits. Such variability, if you're getting in these episodes, then one must consider a neuromuscular junction disorder. Or if you get a difference where they're saying that diurnal variation in the symptoms, or on doing recurrent certain kind of work that they feel fatigue. So it's important to understand what is fatigue, which is quite common in our clinical practice, and fatigability, which happens with repetitive kind of work. So classical examples are, we had one patient who's a carpenter, and when he's trying to nail hammer in a nail into the wall, he says that after the third or the fourth strike, his arm tends to feel heavy and he's not able to do it. So once in a while only you get such history, but those are the classical features of fatigability. The things that repetitive action they are not able to do, or they say that they do a bit of work, then they feel tired, then they go back and lie down, again they do a bit of work. Such persistent fatigability and variability, apart from the fatigability, all this must make one suspicious or consider a neuromuscular junction disorder. Second is, it is a pure motor disorder. There is no sensory in the whole presentation. So sensory is a symptom in the presentation, then NMJ doesn't come into the clinical thought process. Similarly, pain, sensory in the form of pain, paresthesia, tingling, all those things are not a very common symptom in neuromuscular junction disorders. So, and generally, the presentations we generally consider the clinical syndrome where we consider NMJ is when they come with either isolated ocular symptoms, ocular bulbar symptoms, focal midline weakness, or generalized limb weakness, plus or minus ocular weakness. So these are the scenarios where one considers neuromuscular junction disorders. Very rarely one can see limb girdle kind of weakness without ocular involvement, or an isolated orthopnea like presentation. These are quite rare. But in common clinical practice, the first four, in fact, the first two And the first, second, and the fourth one are what normally one sees in our clinical practice. So coming into each one in detail. So what is important to understand is it is episodic, and sometimes it can even spontaneously resolve. So they can come to you with a, for example, a ptosis. This has happened multiple times. Like we have seen patients who in 2009 had come with a right side ptosis, and that had spontaneously improved by the time they came to us and was kept on follow up. Then came with the left eye ptosis after 2 years. Then came the progressive limb weakness. So episodicity, spontaneous resolution even without any treatment, or a progressive worsening. These are the possible causes that you can see with the neuromuscular junction disorder. So coming to ocular presentation, the most common, this is actually the most common. You actually start considering NMJ when you have an ocular kind of presentation. The normal common symptoms that they come with is drooping of eyelid or diplopia or both. So it's quite important when you're seeing a patient who says I have a new onset ptosis to ask them about the onset, because it might be worthwhile even going through old photographs, driving license, passport, to understand, when in time have they developed the ptosis? Is it something truly recent, or is it something which has been there for a long time? So because sometimes patients can have ptosis congenitally, they can have a ptosis after a trauma which has never been given much importance to, or after a cranial nerve palsy. So it is important always to look at clinical photographs, old, which might give us an idea of the onset. Generally, bilateral ptosis is the norm, and it's generally asymmetric. So one eye more than the other, and they can be or not be associated with diplopia. It is very important to understand that the presentation of ocular weakness in myasthenia can mimic any cranial nerve palsy. So it can come as an isolated lateral rectus palsy. It can come as isolated ptosis. It can come as it can even mimic a third nerve palsy where there is a drooping and there is a eyes are down and out. So sometimes if the deficits are quite significant in one eye, the subtle weakness in the other eye may not be picked up in the initial evaluation or when you initially see the patient. So sometimes it's always important to look at the other eye, the non-affected eye, according to the patient. That might give us also certain clues whether that means that the disorder is not restricted to one eye. And the very important thing is again variability in findings. So sometimes important, if you're not very sure on the history, or if the patients are not very clear if there is a variability, we sometimes ask the patients to actually take a photograph of them, so a selfie in the mornings and in the evenings, so that we can understand if there is a variability in the findings. So what you might very well see patients with ocular myasthenia where they go to shell with where they have diagnosed as right lateral rectus palsy isolated. And when they come to you, now they have developed a ptosis also. So a new deficit over time, or initial lateral rectus palsy is completely resolved by the time they come to us. So such resolution, such episodicity, such fluctuations, all these things must make one consider that we might be dealing with an NMJ disorder. So similarly, it can mimic an internuclear ophthalmoplegia-like presentation also, where one eye, there is a abducting nystagmus in one eye and adduction deficit in one eye. So it can mimic virtually any brainstem or cranial nerve presentation. The only important finding that we say in INO is generally convergence is impaired, intact in internuclear ophthalmoplegia. That will be impaired even in neuromuscular junction disorder. So that's why we call it pseudo INO. It's a small tip, might be more useful to the neurology people. Then other important things. So what I'd like to stress on is the variability in the finding, the spontaneous improvement. Similarly, if a patient has on examination both eye closure weakness and eye opening weakness, that is ptosis with eye closure weakness. So both are two different muscles. So ptosis is caused by the levator palpebrae superioris, while the eye closure is by the orbicularis oculi. So if you have both are weak, that indicates that it cannot be a cranial nerve deficit which is accounting for both. It has to be either a muscle or a neuromuscular junction disorder which is causing for that. Similarly, if a patient who has, you think has a facial palsy but has impaired Bell's phenomenon, that means there is ophthalmoparesis concomitant, and that is why the eye is not going up when you are tightly closing the eyes. So such things might also indicate that patient has a concomitant NMJ or muscle kind of disorder. And like I told you, when you have pure motor kind of cranial nerve palsies is when you consider. So Tolosa Hunt is not a differential for myasthenia because pain and headache is the hallmark presentation. So painful ophthalmoplegia is the hallmark presentation of Tolosa Hunt, while here is a painless. So a PCOM aneurysm rupture coming as an acute onset ptosis. Similarly, pupillary involvement is not there with myasthenia gravis in any NMJ disorder. Well, if you get pupillary involvement, then one must consider non-NMJ. So pain, sensory findings, proptosis, vision abnormalities that they can't see through one eye. If all those things are there, then yes, these are all red flags. You should not consider NMJ in them because that indicates concomitant other cranial nerve involvement, which should not be there. So pure motor recurrent presentation. So he came with the right ptosis in 19 2009, left eye ptosis or diplopia in 2011. Then comes with the hoarseness of voice in 2012. So all pure motor cranial nerve palsies. None of them come with any sensory or chewing difficulty, indicating trigeminal motor manifestation. Any of those things. If at any point in time there's a sensory finding, then that means it's more nerve, more sensory nerves, more skull based. While pure motor kind of presentations recurrently happening, one must always consider myasthenia gravis. And it's always important to know sometimes people confuse vision problems with diplopia. I will narrate two clinical scenarios where I have personally encountered. One was the patient from Javadi Hills who kept saying that I can't see the buffalo coming opposite to me. That's what he's saying. That I'm going and hitting the buffalo when I'm walking against it. So which was when I was a PG and I heard this history, I was thinking it as a vision problem. So he is not saying any diplopia or anything. I am considering it as a vision problem. There was a mild ptosis which I chose to disregard at that point in time. And then finally, when the shell examination was normal, brain imaging was normal, when I was thinking it is a field defect, then when you re-look in the history, he says sometimes in the morning I'm better, in the evening I see it's, and after multiple times already, I could understand it is actually diplopia that he's saying as vision problem. So some patients tend to confuse vision problem with diplopia. It might be worthwhile to understand, to go into the final points of the history in such cases. Another patient recently, which I had made a mistake, was a patient came to our OPD where initially he had post-COVID, he had some chest tightness and breathlessness, was admitted under cardio and thought to have unstable angina. Angiogram was normal, was considered to have coronary vasospasm. Then came to medicine OPD with a right lateral rectus palsy and ptosis, was considered to have a orbital sinus syndrome or cavernous sinus syndrome. He's a diabetic, mucor evaluation was going on. Then he came to neurology OPD because the left eye was getting affected. And when the wife was telling me this, the eye had gone out and then came back by itself in a few days. So at that point in time, I was thinking he's recruiting new deficits. This might be a posterior circulation stroke. So I asked him to get an MRI done and come back to me next week. In the meantime, he had fever and suddenly became breathless and was admitted under medicine. Subsequently, the medicine registrar is noting that he has ptosis, he has diplopia, and they have subsequently picked up that this is myasthenia gravis, and patient was subsequently transferred under us. He had crisis, he required intubation, ventilation. So again, diplopia can be mistaken for vision loss, spontaneously improving eye deficits. All those were their hallmarks which were missed. So vision and diplopia sometimes can be confused by certain patients. So this is one photograph which I like to show. This is a patient who has come at rest. So here you can see that there is a mild ptosis in the right eye. But if you notice carefully, there is actually a frontalis overaction bilaterally. This second picture is after making him look up, sustained up gaze for a minute. And you notice that this deficit has now worsened. Now the ptosis is quite more evident in the right eye. But if you notice, even the left eye ptosis is also, as compared to the first photograph, the left eye ptosis is also increased. Subsequently, when you're examining him, so this is what I'm saying, that it might look as though one eye is only affected, but sometimes paying attention to the opposite eye might also give us some clues to the disorder. Now, subsequently, when asking to look up, now you are seeing there's an upgaze palsy, right more than left. He's not able to look to the left. He has difficulty in looking to the right. So it can, like, if this eye was not given much importance, you can even consider this is actually a oculomotor nerve third palsy. He has ptosis. There is ophthalmoparesis in the right eye, medial rectus. So even you might even consider even cavernous sinus syndrome 3, 4, 6 being involved. So here the absence of pain is what might help us. So going back and across only we might understand that NMJ is a likely localization. So similarly, simple things that we can do in OPD is something called as ice pack test. So the patient says that he has such ptosis, such variability, such fatigability. So this is a photograph where a patient has bilateral ptosis. If you can look at closely, the left is more involved than the right. So this is an ice pack, bit of crushed ice kept in a glove or anything that can be kept over the face. And immediately, maybe 2 to 3 minutes later, you can see a dramatic improvement in the ptosis. So what happens is the acetylcholinesterase enzyme effect is retarded when you're giving the ice, and the acetylcholine acts more. And so there is a temporary improvement locally at that muscle. And so in ptosis, you get this. So something even in OPD you can do. or sometimes we do ask them to come to the ward and do it. So in ocular onset patients, these are very simple tests that can be done, and Shell routinely does it for patients who come with isolated ptosis, painless ptosis. And this is a transient phenomenon. As you can see, within 4 or 5 minutes, this effect is waning off. So it's a painless test, non-pharmacological test, which can be easily done in OPD basis. So coming to the next one is bulbar. So sometimes this is again multiple scenarios we have had where it is often considered as an acute stroke, acute bulbar weakness, often mistaken for lateral medullary syndrome, multiple MRIs being done, CT angiogram being done, MRI being normal, and considering this a vacuum which was not seen in the first MRI and repeatedly getting MRIs done. So sometimes the onset of the bulbar symptoms might appear to be acute, where they might have had some minor symptoms which might not have given much importance to. So this is and always in such things, again, fluctuations give us importance. So in the mornings they are better, in the evenings they say they are much more worse. Always generally it is dysphagia more than dysarthria, because the primary problem is in the pharyngeal. Generally dysarthria is not the major complaint. Always if we are both being weak, dysphagia might be the prominent weakness more than dysarthria. But in most of the stroke syndrome, dysarthria will be more involved, like pontine lacunes and all. Dysarthria will be the primary problem. Similarly, in motor neuron disease also, dysarthria is generally the most common problem that they have, more than dysphagia, at least at the onset of the disease. And it's again painless. So pain, if you can have multiple cranial nerve palsy, skull-based osteomyelitis can come with bulbar palsy. Again, absence of pain. So skull-based osteomyelitis will have tear discharge, headache, pain. So that will not be there in such cases. And often bulbar myasthenia in neurology setting is confused between motor neuron disease. So dysphagia more than dysarthria, fluctuations and all, especially the musk phenotype of ALS is often mistaken for motor neuron disease. So it's quite common to see neurology OPDs when a patient has an isolated bulbar presentation, that we'll work up extensively for myasthenia because that is treatable. Bulbar onset will be progressive. So absence of fluctuation and all, tongue wasting, fasciculation, you can have all these things. So generally when patients develop bulbar, it is quite significant to us, because that means that there's a risk of aspiration. Once there's a risk of aspiration, that means there's a risk of a crisis and going on to a ventilator. So bulbar weakness is taken as an important symptom for us, because we have to act at that time if it is truly due to myasthenia gravis. Generally, by the time they develop bulbar weakness, they can have concomitant neck flexor weakness, they can have a neck drop. Single breath count should be assessed also at that time, because these are things where they are progressing or maybe worsening in the clinical picture. And last is again limb weakness, again because the proximal muscles are working more than the distal to maintain posture and all. That's why proximal weakness is more quite a presentation, more quite commonly. So it can mimic a myopathy, especially if ocular bulbar is not a main symptom, or it was a mild symptom. Isolated limb weakness like presentation can be quite difficult into diagnosing. The important points will be that there is no wasting, to say that it's a LMN motor nerve disorder. No, the deepened reflexes will be absent. Selectivity will not be there, which might indicate muscle. CPKs will be normal. So it's important to understand that isolated limb weakness is quite difficult sometimes to diagnose, to bring into NMJ, because this fatigability in limb weakness can often be pushed under the carpet and say that this is routine pains and difficulty in walking, and this is not a limb weakness which is fluctuating. So in the presence of ocular bulbar limb is quite easy to diagnose, but isolated limb sometimes is quite difficult to diagnose myasthenia. So this quite helps us in telling you, like I was just talking about it. So it can mimic any brainstem, or cranial nerve involvement, thyroid, ophthalmopathy, all those things it can mimic. So fluctuation, variability, all those things indicates more NMJ. Progressive syndromes indicate other things. Pain and sensory symptoms indicate nerve. So that's how we go about it. So in patients with mitochondrial disease, external ophthalmoplegia, because it is symmetric involvement, they do not generally develop ptosis, symmetric ophthalmoparesis. But in most of the photographs which I showed you are all asymmetric involvement. So that's why they develop the diplopia. So again, limb weakness, wasting and all will generally not common. So when you have an isolated neck drop, one must consider motor neuron disease, inflammatory myopathy and all that. So concomitant symptoms help in the in localizing. Isolated is quite difficult. Multiple histories and evaluation will be more required. Distal limb weakness is not a common presentation of myasthenia gravis. Generally, it's a proximal limb weakness. So this is another sign which I like to say in ocular, where, so this is what I was saying. So patient has both ptosis and eye closure weakness. So the clinical this thing about it would be correlate would be that when they are in the shower and when they close their eyes and when they are soaping their face, they can't continuously keep their eyelids tightly shut. So soap will go into their eyes. So they'll feel that they'll have difficulty when they are having a face wash. So that's called a peak sign. So continuous eye closure will cause inability to continuously close the eye. That's a fatigability. And the typical presentation of the face where you can see instead of the U-shaped kind of face, it's a transverse kind of facial, indicating there is weakness of the facial muscles. So ptosis, which is there because the frontalis is overacting and this bifacial weakness indicates that it's more than isolated ocular, but there is facial weakness also. So who do they affect the population? It has a bimodal distribution. In the younger ones, it's generally younger, the women which are affected more, and in the older, it's actually more symmetrical, maybe a little more males more than females. In the juvenile presentation, generally ocular presentations are quite common. In the older ones, oculobulbar and bulbar dominant presentations are quite common. That is why in elderly patients, especially 50 to 60-year-old, bulbar presentation is quite often mistaken for stroke, especially if they say it's an acute onset kind of presentation. So among the various subtypes, so we generally divide them into ocular myasthenia or generalized myasthenia, and the early onset ones and the late onset ones. And we often put this thing whether they have associated thymoma or no thymoma. All these things make a difference in the clinical management. The musk phenotype, so generally the ocular and thymoma and all of these are associated with the generalized acetylcholine receptor antibody myasthenia gravis. The musk phenotype is actually the middle-aged woman who comes with prominent ocular bulbar weakness with neck drop and limb weakness. They have a tendency to have significant bulbar weakness with tongue fasciculation, which can mimic motor neuron disease. They can have significant limb weakness. They do not tolerate pyridostigmine well, and so sometimes they are thought that because they are not tolerating pyridostigmine, they are not myasthenia gravis. They have a higher tendency to go on to a ventilator and have crisis. So musk phenotype is a little more aggressive and more severe phenotype. And recently, previously we didn't have antibody testing. Now that also we have in our panel, and so it's been recently a little more easier to pick up these cases. And rarely, only we do not have LRP4 and other antibodies in our panel. Whenever we see a patient with seronegative myasthenia gravis, the first things to look at is, are we really looking at myasthenia? So re-looking at the clinical phenotype, re-looking at the clinical diagnosis, is it more a muscle or is it more motor neuron disease that we are looking at? So re-looking at the clinical phenotype, re-looking at the electrophysiology will be important in these kind of cases. So why is it important to pick up myasthenia gravis? Because of this probability that you can develop into myasthenic crisis. So this is a life-threatening complication of this disease. So generally, a myasthenia can remain as ocular myasthenia all over, or sometimes the onset of the disease can be ocular myasthenia, and over 2 years to 3 years, they can develop generalized limb weakness. If the disease restricts itself to ocular presentation for more than 2 years, we consider unlikely that they are going into limb weakness. They might remain restricted to the eye. So the ones which have generalized myasthenia gravis is what we have more possibility of going into myasthenic crisis. So it's a life-threatening condition. They have significant bulbar and respiratory weakness, which require immediate admission to ICU, intubation, or non-invasive ventilation. This impending myasthenic crisis is what we need to pick up clinically, because once they go to myasthenic crisis, it's like a crash. So once they reach there, then the improvement takes a long time. The whole goal of every myasthenia gravis management is to pick them up when they are just going down. Like I'm saying, when impending bulbar weakness, worsening bulbar weakness, worsening limb weakness, going on to a guy who was walking, going on to a wheelchair now, or not able to swallow food, requiring NG tube. All this indicates there is impending worsening, and these kind of cases should be admitted and optimized as fast as possible to prevent a crisis. So if you look at the course of the disease, previously the ones which had myasthenic crisis had quite a bad mortality rate, nearly 80 to 90%. So once neostigmine came into the clinical picture, thymectomy came into the clinical picture, IVIG and plasmapheresis came into the picture, the ventilation parameters improved, you can understand that the mortality has significantly dropped. Also, once our diagnostic capabilities also improved, then from electrophysiology in the form of ability to pick up these antibodies, the prevalence of the disease has also increased over time. We are able to diagnose them much more earlier and better. So that's how the course of the disease has improved over time. So Indian data, the B.S. Singhal, who's a very senior neurologist from Bombay, has looked at a very large, this is the largest cohort of patients from India, nearly 800 odd patients, and nearly 1.3% of them had myasthenic crisis. And if you follow around 100 odd patients up, generally up to 13, 10% of them can develop some amount of crisis. And it's quite significant because the mortality for those patients are 30%. So 1/3 of them can die. So that number this is in India. So gradually this number will improve as we are able to pick them up early, institute immunotherapy and treat concomitant disease early. So it's important to know that it can happen. It's much more common in the initial part of the diagnosis of the disease, when the first time in the myasthenia gravis is diagnosed. First 2 to 3 years is when the crisis episodes are quite common. Subsequently, as the disease becomes more chronic, then the chance of having a crisis is lesser. And sometimes it's important to know that crisis might be the first manifestation of myasthenia gravis. That's how they might be presenting to you for the first time. So most common precipitant, especially in the Indian scenario, is infection. Sometimes we see drug non-compliance, or we taper the drug and then they develop a worsening. Pregnancy and childbirth, immediate post-surgery, especially after thymectomy, and sometimes as part of disease they can have. This is the rarer part. What we see most commonly in our setup is infection. Especially during the COVID pandemic, we had a lot of patients who had come with worsening in the myasthenia gravis, and this was also complicated by concomitant ARDS, and ventilation was difficult both from the myasthenia point of view and from the lung point of view. So they have prolonged ventilatory state. We lost quite a few patients due to myasthenic crisis during this time. So we have a large retrospective cohort from our institute by Ajit sir, who have looked at around 62 patients who had 89 episodes of myasthenic crisis and been followed up subsequently for nearly 1.5 years. So immediate crisis, the outcome of having the outcome depended on whether they had persisting bulbar weakness at discharge, whether the phenotype was a MuSK antibody phenotype, so they had concomitant medical problems, and whether they had a phrenic nerve dysfunction at discharge. Did they require a BiPAP at discharge? They, long-term ventilation, not just the myasthenia, they also have a critical illness, neuropathy, myopathy, requirement of BiPAP, and all those things made a difference in the immediate crisis post-discharge from the ward. And long-term follow-up depended on what is the thymoma status and cardiac comorbidities. So it's quite important to know that patients with thymoma with myasthenia gravis are the most severe forms, because thymoma is a tumor. It needs immediate surgery and removal, and for which the myasthenia has to be optimized before taking up for surgery. And it depends on how much we are able to remove the tumor. Extensive tumor invasion into the pericardium, pleura, metastasis always indicates that disease might be difficult to control. We've had some few patients who we are still following up in spite of extensive disease, but their prognosis is quite there is a problem. It's also important to understand that those with thymoma with myasthenia gravis have also other concomitant autoimmune diseases. Like in this paper, we have a few patients where one of them actually had initially myasthenia gravis with thymoma with pleural mets. He had a pleural metastectomy. I mean, the mets was removed and the myasthenia was controlled. Subsequently, a few years later, he developed a glomerulonephritis, which was considered to be immune mediated, for which he required immunotherapy. Then he came with a pure red cell aplasia to hematology, which required therapy. And then subsequently, after 4 years, now he's gone into acute myeloid leukemia. Therapy related is what is considered, and he's on therapy. He's been following up for the past nearly 5 to 7 years, 6 years with us. So we've been managing. So concomitant autoimmune diseases are also quite common when you have thymoma associated myasthenia gravis. So long-term follow-up depends on whether the thymoma has been adequately addressed, and cardiac comorbidities also make a long-term prognostic outcome. So briefly coming into the diagnosis of the disease, the first important always is the clinical pattern. Are we dealing with an oculobulbar pattern or a limb girdle pattern? Is that pattern and with fluctuation, with fatigability? If all those things are there, then yes, we are dealing with a NMJ localization. We always first go for electrophysiology and antibody concurrently. So it's important to understand that the specificity of the antibody is only good when you have a generalized myasthenia gravis. So for an acetylcholine receptor, antibodies are quite positive in 80-90%, highly specific and sensitive also in generalized myasthenia gravis. But if you see the ocular myasthenia, it's the sensitivity dramatically reduces. So if a patient comes in isolated ptosis or mild ptosis with diplopia, disease restricted to the ocular, if your electrophysiology is not, is negative, and clinical SHR antibodies positive, is only positive in half of them. So we have a lot of patients with ocular myasthenia where antibodies are negative, but clinical phenotype is fitting. They might be ice pack testing might be positive in the, demonstrating the fatigability and the fluctuation and improvement with pyridostigmine. So both electrophysiology and antibody testing helps. And in those patients who have generalized myasthenia or oculobulbar weakness who are ACHR negative, then we subsequently test for MuSK, which is present in up to 40% of ACHR negative generalized myasthenia or oculobulbar weakness. In patients who have ocular myasthenia who do not generally remain isolated ocular with MuSK, or oculobulbar kind of presentation is what MuSK comes. Isolated ocular weakness is not a common phenotype with MuSK. So in patients who have ocular myasthenia gravis with antibody negative, if clinical phenotype is fitting, IcePack is positive, improvement is pyridoxine is there, that is generally enough. But if you want to demonstrate it is truly NMJ, then the gold standard way of demonstrating it is a single fiber EMG, which is done in few centers and by few doctors here, Dr. Matthew Alexander said, Dr. Prabhakar sir, they do single fiber EMG and they are able to demonstrate that there is a blocking and jitter in the neuromuscular junction. So coming to the electrophysiology, I like to spend a few moments here. So if you remember the pathogenesis aspect of the disease, like I mentioned, there is outpouring of the acetylcholine for every nerve impulse. So for every nerve impulse, from the immediately available pool, you have this quantum of vesicles which are being released, and this pool gets depleted after 3 or 4 nerve impulses. So the mobilization pool has to then give them the next batch or next reserve should be replenished. Then only subsequent nerve impulse will show further acetylcholine release. Now, what happens in myasthenia gravis is the receptors are either not there or they are not functioning, or the acetylcholine is not able to bind to them. And because of that, whatever pool of acetylcholine is being coming out into the synaptic cleft, it is not able to bind, and that is why you do not have certain muscles, enough end plate potentials are not being developed, and because end plate potentials are not reaching the threshold, because they are all or none. If it doesn't reach the threshold, then muscle fiber will not contract, and therefore there is weakness. So we take advantage of this pathophysiology when we are doing a repetitive nerve stimulation, a slow 3 Hz repetitive nerve stimulation. So this is a normal patient. So for every normal patient, every time a nerve impulse comes, you will have an end plate potential which is being produced. So this is a threshold, and every time from the immediate reserve you have the acetylcholine being produced. When that is depleted, the next reserve will come, and because there is adequate amount of acetylcholine in the postsynaptic junction, they develop a end plate potential every time a nerve impulse is given to the nerve. And so even though there is a decrement, as long as it's above threshold, it's by all or none phenomenon, the same amount of muscle fiber action potential is generated for every amount of end plate potential chain that is made. And because multiple muscle fibers will produce the jerk, that will produce a normal kind of compound motor unit action potential. Now, in a patient with myasthenia gravis, because some end plates do not have enough acetylcholine receptors, you see by the third stimulation, there is not enough acetylcholine to act on the acetylcholine receptors, and so they remain below the threshold. So when they remain below the threshold, as you can see, the first, second, and third, and the fourth one reach threshold, and so you have a single muscle fiber contraction by all or none. The moment it reduced below the threshold, no muscle fibers contracted, and the clinical correlate is that the weakness starts. So it's important to understand, even in the muscles, certain muscles are more weak than the other. So it's always important to choose your weak muscles when you're doing a repetitive nerve stimulation. So this is what we see when you make a graph. So in a normal patient, even though the end plate potential is reducing with time, by all or none phenomenon, as long as it crosses the threshold, the same amount of single muscle fiber action potential is developed, same compound motor unit action potential is developed. This is what we are looking at. The CMAP is what we look at in the RNS, and you get the same trace. In a gentleman with myasthenia gravis, you can see that there is a decremental response. The amplitude of the motor unit action potential is reducing. This is a correlate of the end plate potential being reduced. So you see a decremental response. Normally you get a U-shaped curve, because by the fourth or the third and the fourth is when you get a maximum decrement, and then gradually there is a small rise. So this is how a normal decrement will look like in myasthenia gravis. So it's also important. So we take a decrement of more than 10% as significant to say that a patient has a postsynaptic neuromuscular junction defect. It's also quite important to understand that there can be false positive RNS also. For example, in motor neuron disease, also if you do a repetitive nerve stimulation, you can get RNS being positive. Vivek sir always talks about a case where a nurse in SMS Jaipur, when he was a DM resident, had actually come with initially ptosis, diplopia, and facial weakness. Was considered to have Myasthenia gravis, RNS was positive, subsequently developed progressive quadriplegia, bulbar weakness, and depressed sensorium. And then imaging showed a brainstem glioma. A nurse was there. So brainstem gliomas with false positive RNS are also well documented. So it is the clinical presentation which, and the electrophysiology which helps us in diagnosis. We do not, no one does isolated RNS when a patient comes with NMG. We always go do the motor nerve conduction study, the sensory nerve conduction study, the RNS, and then only we make, it is in toto that we make a diagnosis of NMJ, not just with an RNS, is what I'd like to highlight. So based on my finding, when you make a diagnosis of myasthenia, then you have to quantify the severity. To make it simple, that's what we call as the MGFA classification of Myasthenia Gravis Foundation of America classification. This is a universally accepted classification to quantify the severity. So in this, very briefly, 1 is any ocular weakness, so ptosis, diplopia. 2, 3, 4 is mild, moderate, severe limb weakness. A and B is, A is if you have predominantly limb weakness, B is if you have predominantly bulbar weakness. So mild limb weakness with significant bulbar weakness is 2B. Moderate limb weakness with significant bulbar weakness is 3B. Severe or impending myasthenic crisis will be 4B. 5 is if you are intubated, you are a myasthenic crisis. So 2, 3, 4 is mild, moderate, severe limb weakness. A and B depends on whether predominant phenotype is limb or predominant phenotype is bulbar. That's all. And a brief overview on the management of the disease. It's quite important to understand that most of the guidelines for myasthenia gravis come from the West, where that is predominantly affected by the insurance policy. So how they treat is dependent on that. In India, we have to put in a lot of factors like infections, treating the disease. As in any disorder that we treat here, the gender of the patient, the age at which they are presenting to us, the severity of the nature of the illness, all those come into the factor when we are managing them. So initial treatment for any myasthenia gravis is always pyridostigmine. It's a cholinesterase inhibitor. It improves the duration of action of the acetylcholine in the synaptic cleft, and therefore improves the weakness in patients with the postsynaptic neuromuscular junction defect. So pyridostigmine is the first medicine that you should give in a patient who has, if you're diagnosed myasthenia gravis. Sometimes in patients who clinically, electrophysiologically, you might be working in a rural place where you don't have access to antibodies. All you have is a clinical patient. Maybe you don't even have electrophysiology to help you. So if you have a patient with ptosis, with diplopia, you do an ice pack test that is showing significant fluctuation, and history is also concomitant with that. There is no red flags. That is quite enough to say patient has ocular myasthenia. And one can start pyridostigmine and see the response to it. So those are enough in a thing. Subsequently, because it's an autoimmune disease, some kind of immunotherapy is required. So the dosage and and how we treat them depends on how the severity is. It's quite important to understand that in a patient who has significant myasthenia gravis, treating them with high dose steroids, that itself can precipitate myasthenia. The steroids itself, though it is a treatment of myasthenia, high dose steroids, like pulsing with steroids in a patient who has bulbar predominant weakness, moderate weakness, can precipitate myasthenia crisis also. So we in CMC, the way how we manage is actually low dose steroids, and we gradually up titrate them. We try to, if patients come with very severe weakness, very severe bulbar weakness, we actually go for plasma exchange or IVIG. We always prefer plasma exchange to IVIG in patients who come with, because the circulating antibodies are better removed, we feel, and the clinical response is also faster in patients with myasthenia gravis, and also it turns out to be cheaper also for patients with myasthenia gravis. And also we can continue the plex longer as compared to IVIG, which is quite costly. If you have to repeat IVIG again, it's most patients are not able to afford it, while plasma exchange can be continued again for patients. So we tend to stabilize patients who come with acute worsening with plasma exchange or IVIG, and then start them on second line agents like mycophenolate or azathioprine or cyclophosphamide, depending on the severity of the disease, and low dose steroids if at all is required. Sometimes with just pyridostigmine, plasma exchange, we are able to manage them very well. And if there is a thymoma, it is always required in patients with ACG or antibody myasthenia. We have to optimize the patient and then take up for thymectomy. So if there is a thymoma, thymus is removed. No clinical doubt about it, because it will progress. The tumor can encroach into other organs, and if there is metastasis, the prognosis is poor, like I already mentioned in the series that we have from here. There is a role for thymectomy also in patients who have non-thymomatous disease, patients who have thymic hyperplasia. Especially in young females who have significant disease which are not being controlled well with immunotherapy, we can optimize them and then take them up for thymectomy. These are patients with thymic hyperplasia. Why? Because we consider thymus as the primary organ which is driving the acetylcholine, driving the myasthenia gravis. It is because that we find that in those patients who have thymus, they have multiple germinal B centers indicating active production. They have loss of central tolerance, and that is why they have these self-reactive auto antibodies which are produced. So we feel that if you remove they are randomized controlled trials also in NEJM 2017, which has shown that in a select group of patients, young individuals, difficult to treat myasthenia, generalized myasthenia gravis, have not been adequately well controlled with good immunotherapy, adequate dose immunotherapy, there is a case for removing thymectomy even in those cases also. So in the crisis, always the question is first we intubate and ventilate. The first important thing is the patient has come in crisis. So as Matthew Alexander often used to say, do not flog a dead horse. So the first important thing is to respiratory failure is how they come. So it's important to ventilate them as early as possible because they can crash and go down very fast. So intubate them and put them on ventilator. Generally, in patients with myasthenic crisis, we stop the pyridostigmine. The reasons are primarily, most important thing is generally they come with a lower respiratory tract infection. The most common cause actually is pneumonia. So when they're on Gravita, pyridostigmine and all that, it increases bronchoria secretions and it can cause worsening. So we tend to stop because once the patient is on the ventilator, then he actually the ventilator will take care of his breathing and all that. So only at the time of extubation is when we restart the anticholinesterase. We generally stop the pyridostigmine when they come with an acute crisis, and we gradually uptitrate at the time of extubation. We institute therapy to whatever, if infection was the precipitant factor, which is most commonly the case, then if it's a bacterial infection, then adequate antibiotics or whatever is the precipitant cause for patients who come with crisis, and immunotherapy in the form of plasma exchange. That is what we do in patients who have significant cardiac comorbidities, severe hypotension or not able to manage plex, then maybe we go for IVIG, treating concomitant comorbidities. And after the, stabilizing them, they're extubated. Maintenance immunotherapy also needs to be instituted so that, they don't have further myasthenic crisis. A short word on presynaptic neuromuscular junction disorders. They also can present with, their clinical pattern is a little different from myasthenia gravis, where they actually come in a triad of proximal weakness actually starts in the lower limb, significant autonomic features in the form of dryness of mouth, mild impotence, and which might be pushed under the carpet, and areflexia. So they're often considered to be maybe a nerve mimic or a proximal myopathy mimic, and sometimes not picked up. They don't come as aggressively or as very rapidly as a myasthenia gravis. Oculobulbar presentations are actually not very common with them. It's actually lower limb weakness which comes. It's an ascending kind of weakness in which they develop. So we recently, Dr. Angel, Dr. Rohit, and had a recently a patient who would come with progressive gait dysfunction in the form of cerebellar ataxia, and then rapidly progressive proximal upper limb and lower limb weakness and mild ptosis. So he was initially considered to have a cerebellar ataxia and myopathy, and later the electrophysiology demonstrated it was actually fitting into a presynaptic junction. As you can see, when you do, so we normally do 3 Hz low frequency RNS for patients with myasthenia gravis. Here, because it's a presynaptic problem, high frequency repetitive nerve stimulation is shown. So instead of the decrement, we get an increment in their CMAP. And he was diagnosed to have a presynaptic neuromuscular dysfunction. Subsequent PET showed a mass lesion in the lung and adrenal mets. He was also, because of the cerebral ataxia, also had cerebellar hypometabolism. Biopsy of the lesion showed small cell lung carcinoma. So this was a Lambert-Eaton presentation as cerebellar ataxia plus neuromuscular junction disorder. We unfortunately do not have access to antibody testing for B by Q channels here. So this is non-tumoral. So my Lambert-Eaton can be associated with as a paraneoplastic syndrome. It can also come as a non-paraneoplastic syndrome. So isolated Lambert-Eaton is also quite common. Just that the tumoral ones present more fulminantly and more, the disabilities are more as compared to the non-tumoral ones. And if you can see the ones which are more darker in green, so the lower limb weakness and proximal upper limb weakness, what they normally have, the bulbar and ocular is actually milder affected, as shaded by light green here. So this is what we wanted to show, the increment in response that they have with the high frequency RMS, which is what we demonstrated in this patient. So it's also important to know that, as I previously mentioned, NMJ disorders, because there is no blood-nerve barrier, the most common features that you see in casualties is actually neurotoxic envenomation, especially snake bite, young children who are sleeping on the floor, next day develops bilateral symmetrical ptosis, abdominal pain, then progressive bulbar weakness, salivation, then they're going on to the ventilator. In them, the important history is very acute onset. There is no asymmetricity, it's quite generally symmetric, and sometimes even also have pupillary abnormalities, which is not commonly seen with neuromuscular junction disorders. So acute history, very fulminant kind of presentation in a young child. Sometimes you may not get PAMAs, especially with the crate bite and all that. So neurotoxic envenomation is also quite important in our general medicine clinical practice. OP poisoning is also been demonstrated to have neuromuscular junction disorders. David Peter sir has a paper on neuromuscular junction defects presentation in them. And botulism is also considered to be one of the causes of neuromuscular disorders. I have not personally encountered any patients with them. So, but it's a differential that one must consider. Thank you.
Thank you so much, sir, for this lecture. Are there any questions? There are no further questions in the session. So thank you so much, sir.
Thank you.